Good morning, President, Chairman of the Organizing Committee, members of the faculty, ladies and gentlemen. It gives me great pleasure and honor to be here to be invited by the College of Surgeons, Academy of Medicine, under the title Minimally Invasive Transoral Surgery. Before going on to the core or the heart of the subject, I would just like to take a few moments to discuss on the surgical management of oropharyngeal squamous cell carcinoma, that is stage T3 and T4. This surgery is a major surgery and is called the commando surgery for its reason. It involves large incision of the neck and the face in order to enter the oropharyngeal hypopharyngeal area to remove the tumor. This usually renders the patients a poor quality of life in terms of its loss of function, cosmesis, as well as a poor oncological outcome. These patients who usually have a tracheostomy tube and a nasogastric tube usually stays in the hospital for 1 or 2 weeks, and the whole process of healing may take up to weeks. So moving on from there, from the 1990 onwards, there are a few studies, including this one which is mentioned here, the Robotic trial study, has shown that non-surgical organ preservation treatment for oropharyngeal squamous cell carcinoma has similar oncologic outcome as primary surgery and radiation. So from that day onwards, there was a move away from surgery in favoring organ preservation, non-surgical treatment for advanced oropharyngeal squamous cell carcinoma, as they share similar oncologic outcome. The introduction of rigid endoscopy in ENT was certainly a game changer for endoscopic sinus surgery. We no longer need to make facial incision in order to enter the sinuses, and all this is all done with a minimally invasive surgery. As a registrar in ENT, it was difficult to perform surgery in the sinus, especially without the endoscope. Most of these procedures were through experience and was done blindly into the sinuses. Rigid endoscopy transorally was also performed, but with limited practice, as one of hands are not free as is used. We need one hand to carry the surgical instruments, the endoscope, and the other hand to operate. Steiner then introduced the CO2 microlaryngeal surgery for oral and hypopharyngeal tumors, but I feel that the drawback was that he really had to cut through tumor in order to get negative margins, and unless you have done hundreds and thousands of these cases, there's a huge learning curve, and certainly it's not technically simple in that sense. So rigid endoscopy and microlaryngeal surgery has its own difficulty. The surgical field is limited to a line of sight. Instruments is limited in terms of mobility. Scale increases, visual tremors, and dexterity is usually compromised. So we have seen there's a shift away from surgery using the organ preservation, non-surgical treatment for advanced oropharyngeal carcinoma in the 1990s. And certainly in the last 2 decades, there was certainly an interest towards favoring minimally invasive surgery, and the timing coincided with the introduction of TORS surgery using Da Vinci system by 2 surgeons from the University of Pennsylvania, O'Malley and Bert Weinstein, where they performed their first few cases transorally for oropharyngeal cancers. And from then onwards, the FDA in the United States have approved the Da Vinci TORS for certain oropharyngeal cancers. So this is a representation over the use of the evolution of treatment for advanced oropharyngeal squamous cell carcinoma from a time we did major surgery using large facial and neck incision in order to enter the oropharynx to remove the tumor, to relatively conservative organ preservation treatment using chemoradiation, to transoral laser microlaryngeal surgery using CO2 laser, and finally the revolution of treatment, transoral robotic surgery, TORS, using the Da Vinci system. So you might ask why TORS for ENT hip. TORS and its future. I'm sure everyone is very familiar with this data. TORS have been gaining in popularity in treatment of oropharyngeal carcinoma malignancy, both in benign and malignant cases. And in the recent past, several surgeons have even expanded the scope of TORS to include larger tumors, and this may even extend to other areas in the head and neck area that we typically will not perform transoral surgery. So certainly this has clearly pushed us to the surgical boundaries that we can offer transoral robotic surgery, and as such we must relearn our inside-out anatomy in order to understand the complex anatomy in this region. External approach of this region is well described with the transmandibular and transcervical approach. However, the use of transoral approach is more challenging. This is just a representation where the top two pictures shows the comparison between transoral robotic surgery using the Da Vinci, where we operate inside the patient's body cavity, whereas in the microlaryngeal surgery on the right side, we actually operate outside the patient's body cavity. Therefore, the surgery, this form of surgery, is limited in terms of the line of sight, etc. One of the most surgical quotes that I can remember is, "Anatomy is the basic science of surgery. Without proper knowledge of this anatomy, our surgery is more difficult and lead to more complications." I place this slide up, first of all, not to labor too much on the anatomy here, but to illustrate how complex this anatomy can be if we would travel across the pharyngeal constrictor muscles into the lateral pharyngeal space and parapharyngeal space, that we will encounter this major neurovascular structure of the lateral oropharynx and parapharyngeal space, including the external internal carotid system, stylopharyngeal muscle, the styloglossus, various branches of the external carotid artery, as well as lower cranial nerves. So I was fortunate enough before the worldwide pandemic lockdown in February 2020, I visited Florida and underwent a TORS mini fellowship under this great surgeon, Scott Magnuson, and he taught me two lessons of mastery of dissection. First of all, it's docking, and second is instrument movement. So good implementation of docking as we operate in such a limited space in the oral cavity. Good docking will lead to improved surgical exposure, and hence will in turn lead to improved visualization of this inside-out anatomy. So these are three corresponding columns of top and bottom photos. The first row, or first column rather, showing the Da Vinci system being docked at the oropharynx, and this is like us doing a tonsillectomy, where the camera system is the eyes looking straight down the oropharynx, with the two arms of the robotic system similar to our right and left arm operating on the oropharynx in the tonsil region. So all these instruments are in one plane. However, as you move down further down the aerodigestive tract, the two arms of the robotic arms have to come closer to each other in order to prevent clashing of the instruments, and the camera system had to change from 0 degrees to 30 degrees. And the third column shows that as we move down to the hypopharynx and larynx, these instrument arms have to come even closer to each other, and this is how limited the space is when we operate further down the aerodigestive tract, and we need to implement good docking system in order for the camera not to clash upon one another. So these are corresponding videos, top three and bottom three. The top three videos describes one scenario where a surgeon using the Da Vinci transorally, using the endo-wrist technology, but he doesn't use his fingers to move the instruments. Therefore, he uses this instrument as like a laparoscopic instrument, using large movements up and down, and therefore there's a lot of movements and possibility of clashing of instruments. However, as you gain more experience and gain more finesse with the surgery, then you would tend to use more of your fingers as well as your wrists, and you can see the movement is much less as compared to the videos on. Again, these are similar videos. Top three correspond to one scenario, and the bottom three correspond to one video. And notice that the top three videos shows larger movements, with possibility of higher chance of instruments clashing upon another, whereas as you gain more finesse and skills, the movements are much less when you are using both your wrists as well as your fingers to move the instruments along. In summarizing my talk, as you can see from this list, the uses and indication for TORS surgery using Da Vinci system is quite wide and varied. In my clinical practice, the majority of cases I would perform are for severe obstructive sleep apnea, where there's a large lingual tonsils involvement. I will also perform transoral robotic surgery for patients who, after exhaustive investigation, there's still an unknown primary neck tumor. Then I'll proceed to excise the base of the tongue musculature in order to find the primary tumor, as many studies have shown up to 80% of such tumors are actually lurking in the tongue base. And provided you can find the primary tumor in the tongue base and can prove that this tumor is HPV positive, then you can downsize or downregulate the extensive need of chemoradiation, thereby reducing the overall chemoradiation toxicity in this patient. I will end my talk here today, and I would like to thank all for listening.